I first want to introduce Dr. Heidi Connolly, who I'm sure you all know, but is head of our adult congenital heart disease clinic now. She's also actually head of education. Actually, I'll give you a clue on how she speaks and is able to get
Time's up, Nish.
Yeah, sorry, the thing around, and I hear my time's up, which means that we have to go to the question. So let's go to the question. Okay, we're going to have three questions here. One is a 26-year-old woman, 21 weeks pregnant, recent viral illness, presents with chest pain, venous pressure normal, and she's got a pericardial friction rub. So you heard from Steve how you go ahead and treat these patients, only this patient's now pregnant. So the management, nonsteroidals, corticosteroids, observation, or warfarin anticoagulation. Let's go ahead and answer.
Good, that's what we want to see.
Before.
That's right. Learning opportunities.
All right. 29-year-old woman, first pregnancy, referred for hypertension. So remember what Amy gave you the talk on hypertension. Asymptomatic, no medications, normal labs, blood pressure is 156/96, heart rate is 80, apical fourth heart sound, no murmurs, pulse is normal. On the ambulatory blood pressure monitoring, she's pretty high, 155/90. Which of the following is the most appropriate treatment for this woman who's pregnant? Labetalol, diuretic, losartan, or no therapy is necessary? %, said no. Okay, 32-year-old woman, 3 weeks postpartum now, presents to the ED with chest pain and diaphoresis, no history of CV disease, blood pressure is 130/80, heart rate 90, no murmurs or rubs, lungs clear. And you say, oh,
Nish, never.
No, but this is, wow. Okay, so everybody can see that. So what's the most likely cause? Dissection, coronary disease, coronary dissection, coronary artery embolism, or stress-induced cardiomyopathy? Okay.
Okay.
Do you want to educate us?
I'll give it a whirl. How about that? All right, I have no disclosures. It is worth mentioning that there are ESC guidelines on the management of patients who have cardiovascular disease in pregnancy, and they are referenced in this presentation. This is an important topic not just for the boards, but about 2% of pregnancies will involve some form of maternal cardiovascular disease. And cardiac disease does not preclude the possibility of pregnancy, but does increase the risk to both mother and fetus. Data published earlier this year emphasize that in the United States we are not doing a good job. You can see from this graphic that maternal mortality is rising in the United States, and that's in contradistinction to other developed countries. It's also very important to note that cardiovascular disease is the most common cause of maternal mortality. 700 to 900 maternal deaths occur each year, and I think we can really do better, and that's the reason that we're discussing this topic today. So I have 5 learning objectives. Let's go through one at a time. The first is to explain the physiologic changes which occur during pregnancy. You remember from physiology that there are important changes that occur during pregnancy: an increase in plasma volume, a lesser increase in red blood cell mass, resulting in a relative anemia. But note here that by the time the pregnancy has come to term, the whole blood volume is about 40% above the pre-pregnant level. And it's this change in blood volume associated with slight changes in systemic and pulmonary vascular resistance and heart rate that result in an overall increase in cardiac output of about 30% during pregnancy. Of course, this change is usually well tolerated, but in the setting of cardiovascular disease, you can understand why problems might occur. The most common referral of a pregnant patient to cardiology or imaging is that of a murmur. And it's noteworthy that over 95% of patients who are pregnant will have a systolic murmur. Note also that a third heart sound is very common, present in 84%. And so I think that we need to emphasize that the normal findings of a pregnancy will often mimic cardiovascular disease. So brisk and full carotid upstroke, venous pressure might be slightly elevated, displaced and enlarged apical impulse, varicose veins and lower extremity edema. But it's very important to remember that the normal physical exam during pregnancy should not include a loud systolic murmur. It should not include a diastolic murmur. It shouldn't include a fourth heart sound, and fixed splitting of the second heart sound should not be present. So additional important changes occur during labor and delivery. The cardiac output increases further, 60 to 80% above the pre-pregnant level, and of course there are associated changes in heart rate and blood pressure. There are also important volume changes which occur. Initially, as the uterus contracts, there's an increase in blood volume. Also, as the fetus is delivered, there's that increase in venous return, and then, of course, volume loss after delivery. And one of the common misconceptions is that cesarean delivery is better for patients who have cardiovascular disease than vaginal delivery, and this is in fact not the case. Vaginal delivery is preferred in all circumstances, and sometimes we'll recommend a facilitated second stage. There are, however, some exceptions. Number one, obstetrical reasons. In that situation, of course, cesarean delivery might be needed. Number two, the mother is fully anticoagulated with warfarin. Remember that the fetus is also anticoagulated, and so there's an increased risk of fetal intracranial hemorrhage if a normal vaginal delivery occurs. And then there are rare cardiovascular reasons that we might recommend a cesarean delivery. For example, unstable cardiovascular disease, a very dilated or enlarging aorta, and so on. But it's a case-by-case selection in this situation. Our next learning objective is to list and remember the contraindications to pregnancy for patients who have cardiovascular disease. And really, again, just to re-emphasize that this is something you really have to use on a daily basis. If you're seeing women of childbearing age who have serious cardiovascular disease, counsel them regarding contraception and pregnancy. The first and most important contraindication to pregnancy is severe pulmonary hypertension. Even in the current era where we have excellent medical therapy, there's a 30 to 50% risk of maternal mortality. Obstructive cardiac lesions and ventricular dysfunction, additional contraindications to pregnancy before intervention. And remember, we'll talk about ventricular dysfunction. Our best medical therapy is not safe to use during pregnancy, and that's why these patients can get into significant difficulty during a pregnancy. Additionally, and we'll talk about each of these in some more detail, a dilated aorta. The Marfan patient with an aorta over 40 millimeters, we would counsel against pregnancy, or between 40 and 45 millimeters, and we'll talk about that in some more detail. And finally, cyanosis is a recognized handicap to fetal growth and development, and so it's a relative contraindication to pregnancy. When we see patients who want to either consider pregnancy or are pregnant, we want to ideally go through a pre-pregnancy evaluation, work closely with our maternal fetal medicine colleagues, obstetrics, OB anesthesia, and other colleagues to provide multidisciplinary care once the patient is pregnant. And then, of course, the postpartum period is an area or a time when special circumstances need to be considered. There are some patients who can get into trouble in the postpartum period. Of particular note is patients who have an intracardiac shunt, patients with a dilated aorta. The highest risk for these patients is in the postpartum period for aortic dissection, and then certain select cardiovascular other problems can occur in the postpartum period. Now, time won't allow us to go through each of these pre-pregnancy risk assessments. They're in your handout, and you can review them in detail. The Canadian, the European, and the World Health Organization all have nice reviews on how to assess the patient who's considering a pregnancy with regard to cardiovascular risk. So we'll turn now to our third learning objective, and that is to select appropriate management strategies for pregnant patients with myocardial, valvular, aortic disease, arrhythmias, and/or hypertension. You're going to hear two elegant presentations by Dr. Carol Warrens shortly about congenital heart disease. And I think that this is really a topic that's very important, not just to know congenital heart disease, but also to remember that the most common cause of structural heart disease affecting women of childbearing age is congenital heart disease in the United States. And so patients who have complex anatomy, as demonstrated here, this is a schematic of a mustard or atrial switch procedure. We need to not only know what the patient has, but what the likelihood of a problem is around the time of pregnancy and what kind of problems to look out for. So in the past, there's been uncertainty with regard to the possibility of conception, the chance of pregnancy outcome, and the effect of congenital heart disease on both mother and fetus. But now with increasing information, we really are able to adequately advise patients. And in this situation, of course, pre-pregnancy evaluation is crucial. The presence of simple forms of congenital heart disease doesn't, of course, mean that the pregnancy is going to be simple. In fact, my most challenging patient this year was a patient who had a relatively simple congenital cardiac lesion, but became acutely ill right around the time of delivery. So again, just to emphasize, these are patients that require special evaluation and expertise. Dr. Warrens, Mary Canobia, and some of the rest of us were able to put together a document that in great detail covers the management of complex congenital heart disease in pregnancy, and the reference is outlined here, published earlier this year in Circulation. Now remember that congenital heart disease can be genetically triggered, and so especially in test type of settings, you might encounter a patient who has a congenital heart defect and, let's say, an abnormality of the upper extremities, the so-called heart-hand syndrome or Holt-Oram syndrome. Think of that because it's important from test taking and also from a practical standpoint. These patients are at a much higher likelihood of having an offspring with congenital heart disease, with a 50-50 chance of affected offspring. Turning our attention now to aortic disorders. You heard a very nice presentation about aortic disorders earlier in the course. And this is also an important topic for the patient who's considering pregnancy. So here's a 20-year-old female. Let's look at a case in this situation. I'm going to ask for your input. She comes to you for pre-pregnancy counseling. She has a personal history of Marfan syndrome, a family history of Marfan syndrome, a first-degree relative, her mother, who had an aortic dissection, and the patient and other family members have ectopia lentis. Our patient's asymptomatic, and her cross-sectional imaging suggests a normal aorta with the exception of the aortic root, which measures 41 millimeters. And here's a still frame from her echocardiogram, which also demonstrates exactly the same measurement, 41 millimeters. So the question is, what would you recommend? Number one, okay to proceed with pregnancy. Number two, avoid pregnancy. Number three, start beta blocker before pregnancy. Number four, start an angiotensin receptor blocker before pregnancy. Let's look at the responses. Okay, so most of you would avoid pregnancy, and that's exactly correct. That's what I would recommend for this patient. And let's go through some of the details. Remember, in patients who have Marfan syndrome or other genetically triggered aortic disorders, you have those pre-existing medial problems with the aorta. That superimposed on the physiologic and hormonal changes that occur during pregnancy result in an unpredictable risk of aortic dissection and rupture. Even when the aorta is less than 40 millimeters, those patients are at higher risk for aortic dissection and rupture around the time of a pregnancy than individuals who don't have the disorder. There are other problems, of course, that can occur during the pregnancy, and then one needs to remember the autosomal dominant nature of this disorder and counsel the patient appropriately. Now, you heard that there's a mouse model of Marfan syndrome. Dr. Dietz and others have identified that removing the pup from the Marfan mouse shortly after delivery actually decreases the chance of that postpartum aortic dissection. And although this hasn't yet been translated into humans, there's a concern that oxytocin, the hormone that allows lactation, may in fact be the source of that increased risk of aortic dissection in the postpartum period. Again, not enough information to counsel our patients against lactation, but something to keep your eye open for in the future. So how do we address these patients prior to conception? We want to do a detailed cardiovascular history, family history, of course, very important, and look carefully at the medications that they're taking. Remember, many of these patients now are on angiotensin receptor blockers. Imaging, echocardiography, and cross-sectional imaging I do on all patients prior to considering a pregnancy. And then we've already discussed this a little bit. If the aorta is less than 40 millimeters and there are no high-risk features, it's probably reasonable to go ahead with pregnancy, again with that caveat that nobody is without risk. If the aorta is over 45 millimeters or more, then we would recommend operative intervention before considering a pregnancy. And if it's in between, we need to risk stratify, family history, aortic dissection, rate of aortic enlargement, and all of those things then come into play. I already mentioned genetics, and just to emphasize for our patients, there is the potential for genetic pre-implantation diagnosis of Marfan syndrome and other genetic disorders that should at least be reviewed with our patients. So once the patient becomes pregnant, very important to treat them with beta blockers, even if the aorta is normal size. That would be now recommended. We'd also image the patient regularly during pregnancy, somewhere between every 4 and 6 weeks, with reassessment of the aortic size. Fetal echocardiography is also recommended. The peripartum period, facilitated second stage, rarely a cesarean delivery. And then, of course, endocarditis prophylaxis if we feel that patient is at higher risk than normal for a complication related to endocarditis. And these patients with Marfan syndrome probably are if they have substantial cardiovascular disease. The postpartum period, as I alluded to, is the highest risk time for these patients to have dissection. So we want to follow the patient and see them at least 4 to 6 weeks after delivery and counsel them if they should have sudden symptoms that they should present emergently for evaluation. Now, the management of other aortic disorders is similar, with thresholds being lower for the higher risk aortic disorders such as Loeys-Dietz and somewhat higher for the less aggressive types of vascular disease such as bicuspid valve-related aortopathy. Let's turn then to another topic and start with a question when we introduce this topic. 35-year-old female presents to the emergency department for progressive dyspnea, 2 weeks postpartum, no prior history and physical exam, tachycardic, blood pressure 100, respiratory rate 25, venous pressure elevated. She has a grade 2 apical systolic murmur, third and fourth heart sounds, has crackles in both lung bases and lower extremity edema. And the question is, what's the most likely diagnosis? Pulmonary embolism, ischemic cardiomyopathy, peripartum cardiomyopathy, or stress-induced cardiomyopathy? We can show the answer anytime. Excellent. So, excellent. Fantastic. So, we can really skip this topic, I think. Well, let's go through it just very briefly. Exactly. It's not the presentation of pulmonary embolism. That would be the other really high-risk situation for this patient. So peripartum cardiomyopathy, a diagnosis of exclusion, usually identified in those first 3 months after delivery, as demonstrated here in this graphic, but can be identified either prior to delivery or up to 6 months postpartum. The incidence varies in different countries. You'll note here that it's the most common in Haiti, 1 in 300 cases, a little less common in South Africa, 1 in 1,000. And in the U.S., it occurs in about 1 in 3,200 deliveries. The frequency is increased in older women, multiparous women, the individuals who are having multifetal pregnancies, the Black population, and patients who have cardiovascular risk factors. Hypertension, diabetes, and smoking all seem to increase the chance of peripartum cardiomyopathy. Now, what about the pathophysiology? When there's a long list like this, we know that the cause is really not known. And every few years, there's a new thing that we add to this list. But really, we don't know what the cause of peripartum cardiomyopathy is at this point in time. And therefore, the management really is supportive. Heart failure, medical therapy, and of course, the therapy that we use depends on whether the patient has delivered or not, but would include angiotensin receptor blocker or ACE inhibitors if the patient is postpartum. Bromocriptine has waxed and waned in popularity. I've included the dosing here for your reference. In the United States, it's not used very frequently, but in other countries, it's actually been demonstrated to be effective with improved outcome and increase in ejection fraction compared to standard therapy. What about anticoagulation? We would recommend anticoagulation if the ejection fraction is less than 35% at time of presentation, or if the patient is treated with bromocriptine. And then advanced therapy, life vest, ventricular assist device, ECMO, and transplantation are sometimes required for the extremely ill individual who presents with peripartum cardiomyopathy. A common question that I receive after giving this lecture is, how long should we continue medical therapy? And the answer is, we don't honestly know, but you should continue it at least for 1 year, and then regular reassessment, taper down medical therapy, but regular reassessment of ejection fraction is critical. And recurrent ventricular dysfunction can occur even once ejection fraction has normalized. There's one multi-center prospective study that's been published on the outcome of pregnancy in patients with peripartum cardiomyopathy. And one can see here that this does carry a poor prognosis. At 1 year follow-up, most patients recovered, but 13% had major adverse events or persistent severe reduction in ventricular function. And particularly important is the fact that this is a disorder that has an increased incidence, but also an increased risk in the Black population. More LV dysfunction at presentation, and worse outcome at 6 and 12 months postpartum. And finally, from this prospective study, ejection fraction of less than 30% or a dilated ventricle with an end diastolic dimension greater than 60 predicted poor outcome in this population. What about subsequent pregnancy? From one series that was reported now almost or over 15 years ago, we know that adverse effects can occur in the setting of normalization of ejection fraction and, of course, in those patients whose ejection fraction remains reduced. And so, in general, we would advise against pregnancy if the patient had ejection fraction less than 25% at the time of presentation or has persistent reduction in ejection fraction. And there's some factors that can be used to risk stratify, but they're actually relatively novel. What about treatment of patients who have heart failure during pregnancy? The management is, of course, challenging, as I alluded to, because medical therapy that we use so commonly cannot be safely used. So we think about digoxin, hydralazine, beta blockers, and then diuretics when necessary. We tend not to use diuretics unless absolutely necessary. But ACE inhibitors, angiotensin receptor blockers, and aldosterone antagonists are not safe to use during pregnancy. During the first trimester, they cause cardiovascular and neurologic developmental problems, and during the second trimester, they cause urogenital abnormalities. And so these agents should not be used during pregnancy. Now, I know that you all are interested in acute pericarditis, particularly as it involves pregnancy. It is noteworthy that there really aren't many series that have reported the outcome of pericarditis in pregnancy, but you heard that there are guidelines from the ESC, and in these guidelines it's recommended that patients who have acute pericarditis presenting at less than 20 weeks be treated with nonsteroidals, at more than 20 weeks be treated with steroids. So just to re-emphasize, acute pericarditis can occur in pregnancy. If patients don't have high-risk features, they can be treated as an outpatient. And if greater than 20 weeks gestation, corticosteroids are the treatment of choice. That brings us to the topic of cardiac drugs in pregnancy, and just a few things to emphasize. Number one, most drugs cross the placenta and are secreted in breast milk. One needs to therefore weigh the risk-benefit ratio of any medication used during pregnancy and lactation. Use drugs with the longest safety records, prescribe the lowest dose, and try to avoid drug-drug regimens. And then, of course, remember that no drug is completely safe. That brings us to our fourth learning objective: identify medical therapies that are contraindicated in the pregnant patient with heart disease. And I've put this into table format, and really it's good to look at this, a day or so before you take the boards. But in general, aspirin, low-dose aspirin, metoprolol, labetalol, hydralazine, and lidocaine are safe to use during pregnancy and lactation. Adenosine is the treatment of choice for supraventricular tachycardia that presents during pregnancy. The safety during lactation is not clear. We talked about ACE inhibitors and angiotensin receptor blockers. Those should not be used during pregnancy, and safety needs to be checked for each individual agent for lactation. Amiodarone and bosentan should be avoided for both. And then diuretics and diltiazem, use when needed during pregnancy, but okay to use during lactation. And every year the list gets longer. What about the direct oral anticoagulants? Clopidogrel, sildenafil, we just don't have enough information yet, but I thought just to include it in this topic. Treatment of hypertension, again, this is from the European guidelines, and I just want to emphasize, if the patient has a systolic blood pressure over 150 and a diastolic pressure greater than 95, drug therapy is recommended. Lower than that, non-pharmacologic therapy. Higher than 170 or 170 systolic, 110 diastolic, hospitalization for therapy is recommended. Now, another thing that has come up in the last few years is that preeclampsia is actually a risk factor for later cardiovascular disease. Future risk of cardiovascular morbidity and mortality is related to the severity and number of preeclampsia episodes. Early onset severe preeclampsia carries an 8 to 9-fold increased risk of eventual cardiovascular disease. But mild, late preeclampsia is probably not a risk factor. Now, I guess you guys thought you were done with arrhythmias after yesterday, but maybe not. So this is a 29-year-old pregnant patient who comes to your emergency department with palpitations. She's awake, alert, and talking to you. What would you recommend? We can show the answer anytime. I'm expecting 100%. Oh, almost. So the correct answer is intravenous adenosine. The other agents do cause a decrease in blood pressure, although verapamil and beta blocker have been used in select circumstances. Adenosine is the treatment of choice. If the patient comes in and is an extremist, of course, cardioversion would be the treatment of choice, but in acute symptoms, adenosine is recommended. If the patient has recurrent episodes of supraventricular tachycardia, beta blocker, calcium channel blocker, sotalol, flecainide can all be used. And in the extreme situation, although we advise against it routinely, amiodarone and ablation have sometimes been required. Coronary disease is an important topic to address because it's actually increasing in frequency in patients who are pregnant or considering pregnancy. And it carries a high mortality because we as providers are not comfortable treating patients who present with acute issues as we would other patients. So the usual risk factors with the addition of eclampsia and preeclampsia. Treatment, we'll talk about medical therapy in a moment, but in the acute setting, probably a bare metal stent is the way to go because of the concern about clopidogrel and other agents, the safety in those patients. And then we'll talk about spontaneous coronary dissection in just a moment. So initial medical therapy, heparin, aspirin, beta blockers, and nitrates. Remember that nitrates can be excreted in breast milk, so can potentially cause problems for the fetus. And then clopidogrel, glycoprotein 2B3A inhibitors, and dabigatran. The safety really has not been established during pregnancy, and because of that, in general, we would avoid drug-eluting stents. If a patient with established coronary disease wants to have a pregnancy and is on statins, one needs to carefully weigh the risk-benefit ratio because of recognized concern about teratogenicity. So the question you all did very well on is about spontaneous coronary dissection. Marisha Tweed and others in our group have had a particular interest in this and published data actually earlier this year. This is the most common cause of pregnancy-associated myocardial infarction. Usually presents in the first month postpartum. The mechanism is not fully delineated, but these patients are unique as compared to other SCAD patients in that they have a more acute presentation and high-risk features, and that the other associated disorders, such as fibromuscular dysplasia, is less frequently associated with this disorder. So SCAD, again, pregnancy-related, a very important thing to think about. So let's look at we have two more questions embedded here. This is a case of a 30-year-old female who presents with dyspnea during pregnancy. And here's her echocardiogram, mitral mean gradient 15. And the question is, what would you recommend next? Percutaneous intervention, number 1. Number 2, deliver the fetus. Number 3, amiodarone. Number 4, direct current cardioversion. Number 5, beta blocker. Okay, you can tell the interventionalists in the house. So this patient indeed has mitral stenosis. You saw the mean gradient of 15. What was the heart rate? Anybody pay attention to that? Might be important. So the patient was treated with beta blocker. At a heart rate of 95, the mean gradient was 15. At a heart rate of 60, the mean gradient was 4. So would you like to ask the question again? Maybe not. So mitral stenosis, remember, these patients don't tolerate rapid heart rates, whether it's atrial fibrillation or sinus tachycardia. So remember, it's diastolic filling that's affected that can further increase left atrial pressure, and patients can develop pulmonary edema. So beta blocker therapy, maintain sinus rhythm, anticoagulate if they're high-risk features, and diuretics, and then only intervene if those initial therapeutic options are not successful. Similarly, patients with aortic stenosis can get into trouble around the time of pregnancy. They can't augment their cardiac output and can have problems with their pregnancy. Valve surgery may be required in patients who are of childbearing age. And in general, we would select tissue valves in the United States, although in most countries, mechanical valves are preferred in this population. The problems with tissue valves, of course, degeneration, the requirement for reintervention or reoperation, And then there's that concern of accelerated degeneration that can occur during pregnancy. The alternative, mechanical heart valves, it's noteworthy and important to emphasize that only about 58% of pregnancies in the setting of a mechanical heart valve will have an uncomplicated live birth. So these patients are extremely high risk and require centralization of care and pre-pregnancy counseling. And we're going to talk about this in some detail. And that brings us to our fifth learning objective, that is to develop anticoagulation regimens for pregnant patients with mechanical valve prostheses and to treat appropriately. This is a 25-year-old asymptomatic female, mechanical St. Jude mitral prosthesis. She seeks pre-pregnancy counseling. She's on warfarin 4 milligrams a day and aspirin 81 milligrams a day, and her examination is consistent with a normal mechanical valve prosthesis. And the question is, which of the following would you recommend when the patient becomes pregnant? Number 1, stop warfarin and start aspirin and apixaban. Number 2, stop warfarin and start weight-based low molecular weight heparin. Number 3, stop warfarin and start unfractionated heparin, 5,000 units sub-Q, twice daily. Or number 4, continue INR-adjusted warfarin. And so the most common answer is continue INR-adjusted warfarin. Okay, let's go through. We're going to go through this question again in the post-test. So pregnancy is a hypercoagulable situation. Increased clotting factor concentrations, increased platelet adhesiveness, and reduced fibrinolysis increase that risk of thrombosis. And when in the situation of a mechanical valve prosthesis, we have the double jeopardy sort of situation. What is the risk to the mother? What is the risk to the fetus? And unfortunately, the safest thing for the mother is usually the riskiest thing for the fetus and vice versa. So let's look briefly at the anticoagulation options. Warfarin has a low molecular weight. It crosses the placenta, so the fetus is fully anticoagulated. This, however, is the safest treatment for the mother to prevent prosthetic valve thrombosis. We know that embryopathy risk now is associated with the dose of anticoagulation. The higher the dose of anticoagulation, the higher the risk of embryopathy. So if the dose is less than or equal to 5 milligrams a day, the risk of embryopathy is low, as demonstrated here. So no embryopathy in this series when the dose was less than or equal to 5 milligrams a day. But 9% risk of embryopathy when the warfarin dose was greater than 5 milligrams a day. Unfractionated heparin. The one thing I can tell you about unfractionated heparin is that it's the treatment of choice around the time of delivery. But otherwise, it's really not a great anticoagulation option during pregnancy and should only be used in select circumstances. And you can read some of the other issues that can occur with that. Low molecular weight heparin is attractive, administration ease and other things about it. But the concerns about low molecular weight heparin are that weight-based low molecular weight heparin is not an adequate form of anticoagulation in the pregnant patient. We need to measure anti-10A levels and adjust the dose of low molecular weight heparin appropriately. So from the guidelines, the patient with a mechanical valve prosthesis who's on warfarin, a dose of less than or equal to 5 milligrams a day, the treatment of choice is to continue warfarin therapy. If, however, the patient or their family elects not to go with that, the other options are dose-adjusted low molecular weight heparin or dose-adjusted continuous intravenous unfractionated heparin. In the patient with mechanical valve prosthesis whose dose of warfarin is greater than 5 milligrams a day, for that first trimester, go with either low molecular weight heparin, again, anti-10A adjusted, or unfractionated heparin, again, PTT adjusted. For the second and third trimesters, warfarin is the treatment of choice, and then around the time of delivery, somewhere between 36 weeks, we would stop warfarin, admit the patient to the hospital, start intravenous unfractionated heparin, and then, of course, start up the warfarin as soon as the delivery has occurred. Low-dose aspirin can be safely used, but antithrombotic effect has not been proven. It's useful in patients who have valve prostheses, as you heard earlier today, and should be continued during pregnancy. Thrombolytic therapy can be used during pregnancy in the emergency setting, and then we really have no safety information about some of the other newer agents. What about endocarditis prophylaxis? We tend to favor using it in the setting of the very high-risk patient around the time of delivery, but guidelines don't recommend this routinely. And in fact, it's not required in most circumstances. So in summary, pregnancy, cardiovascular disease occurs in about 1% to 2% of pregnancies. And remember that it's the #1 reason for maternal mortality in the United States. We can do better. Congenital heart disease is the most common form of structural heart disease affecting women of childbearing age. The presence of heart disease doesn't preclude the possibility of pregnancy, but increases the risk to mother and fetus, and individual assessment, preferably prior to conception, is recommended. So we've gone through the physiologic changes that occur during pregnancy, the contraindications to pregnancy, management strategies for select types of cardiovascular disease, contraindications for typical medical therapies that we use during pregnancy, and then discussed anticoagulation management during pregnancy. Thanks very much for your attention.
Will I have a seat? I told you that'd be great. So let's go ahead and talk about this 26-year-old woman who's 21 weeks pregnant, recent viral illness, chest pain, venous pressure normal, pericardial friction rub. So the management during pregnancy of this woman with the pericarditis: NSAIDs, corticosteroid, observation, or warfarin.
So you're not supposed to say what the diagnosis is.
Oh,
just in case.
I don't know the diagnosis, but how are we going to treat her?
It's a, deductive.
Yeah.
Right.
Hopefully she doesn't have that ECG you showed. Okay, 85%.
So there's still some that would say nonsteroidals. Again, somewhat limited data, but the guidelines from the European Society of Cardiology would suggest that if the patient is over 20 weeks pregnant, then steroids are the way to go. The concern, of course, is nonsteroidal anti-inflammatory agents during pregnancy can potentially cause problems. And so that's what's recommended from the ESC guidelines.
And there was a question on the portal about colchicine. Can you use colchicine during pregnancy?
It's not recommended during pregnancy.
Okay, because those microtubules and stuff might be a problem.
Which microtubules?
Those little microtubules. Okay. And then
what organ is that?
high dose aspirin.
We wouldn't recommend high-dose aspirin, particularly late in pregnancy, because of the concern for duct closure.
Okay, sounds good. So less than 20 weeks, non-steroidals, greater than 20 weeks, corticosteroids. Boy, I learned something.
That's
okay,
good.
that's
hey,
good.
There's always hope for you.
Okay, 29-year-old woman, first pregnancy, referred for hypertension now at 21 weeks. Asymptomatic, no meds, normal labs, blood pressure whopping. Ambulatory blood pressure still up. What the following is the most appropriate treatment? Labetalol, diuretic, losartan, or no therapy?
Excellent. Yeah, excellent.
So they clap if it's more than 95%. Okay. You got it. Any thoughts?
Yeah, so losartan shouldn't be used during pregnancy, and the ESC guidelines would recommend that this patient be treated, as we discussed, and it'll come up as the next slide. And so really the question is it labetalol or diuretics? And we try to avoid diuretics whenever possible during a pregnancy. So labetalol is the treatment of choice. And here, just highlighted that drug therapy is recommended when the blood pressure is at that level.
Okay, so a couple other questions. Not only during pregnancy but lactation, labetalol, metoprolol, Coreg, is there a metoprolol or labetalol or Coreg, is there a difference in which one you would use and stuff?
We have the most experience with metoprolol for cardiovascular problems and labetalol for hypertension. So that would be hypertrophic cardiomyopathy and aortic disease. We would generally use metoprolol. In fact, atenolol, there's some older data that suggests that that's not as good an agent for patients who are pregnant, but it's pretty weak information, and in fact, some suggest continuing atenolol, but because that information has been published, people are reluctant to use it. So in general, we would transition from atenolol to metoprolol or labetalol, either of those two.
And then once they deliver during lactation, are you going to change any of the medication? Is there anything that's contraindicated in lactation?
And just go back to the graphic and look up during pregnancy and during lactation. So there are some of the agents that we use during pregnancy that we would not routinely use during lactation, but it's very rare.
Okay.
So.
And then let me see they asked about the calcium blockers, amlodipine and nifedipine. Do you ever use those during pregnancy?
Yes, rarely we do use them. They can be used, but they tend to cause problems with progression of labor, and so often need to be discontinued around the time of delivery. So not an ideal medication.
And then somebody asked, since you can use beta blockers well, and you had that thing about the antiarrhythmics, can you use sotalol in pregnancy?
Yes, and it was actually on that slide, so you might want to just go back to that slide and look at it once more. But flecainide and sotalol are actually not only used for maternal arrhythmias, but for fetal arrhythmias, so it can be safely used during pregnancy. We've had one patient who had very recalcitrant atrial arrhythmias with associated, or atrial fibrillation actually, with associated ventricular dysfunction, who we initially treated with multiple agents, not successful, ultimately amiodarone, and then she went on to ablation during pregnancy. But that's very, very unusual, very unusual. So.
Before we move on, though, because you talked about the contraindications to pregnancy, and there were a few questions on aortic disease. May I ask you those questions?
You can, yes.
Okay. So you talked about Marfan's at about 4 centimeters. Then they want to know about
between 4 and 4.5 centimeters.
To not have them get pregnant.
Yeah, and again, it's the high-risk patients. You would tend to intervene earlier, and the patients that don't have high-risk features, then you would let them have a pregnancy a little bit with a little larger aorta.
And they asked, if you intervene, can they then get pregnant?
Well, can they is one question, but should they is another. So I've had a number of patients who had valve-sparing root replacement who have gone on to have safe pregnancies. So yes, there are some case reports in the literature of catastrophic dissection. So it depends a little bit on the indication for intervention. If the patient had aortic dissection that required operative intervention, we would counsel that patient against having a pregnancy. Okay. If it was an elective valve-sparing root replacement, then it's reasonable, assuming that the rest of the aorta looks normal. Okay. And that patient should also be monitored regularly during pregnancy and also continued on a beta blocker.
And Juan Bowen, who, by the way, gave a spectacular talk, he must have been coached, talked about Loeys Dietz and talked about the aortopathy with a bicuspid valve. Yes. Is there a difference in pregnancy versus Marfan's in those two situations?
Yes, so Loeys Dietz, vascular EDS, those sorts of disorders that carry a high risk of aortic dissection or other blood vessel dissection, in those patients we worry more about pregnancy. And again, case-by-case assessment really is required. Of course, there are reports of successful pregnancy in both of those types of disorders, but again, really very conservative. Bicuspid valve, our threshold goes up a little bit with regard to pregnancy safety, but again, it depends on size of the aorta, rate of aortic enlargement, and then associated valve disease, of course.
Okay, but more lenient than with Marfan's.
Yes, in general. Again, you need to be careful that there isn't something else going on there, that there isn't a family history that's associated as well. So.
All right, let's go to the next case. It's a 25-year-old woman, asymptomatic mechanical St. Jude's MVR, seeks pre-pregnancy counseling. Warfarin 4 milligrams per day, aspirin 81 milligrams per day. Her examination is a normal mechanical S1 without an elevation of venous pressure. Which of the following would be the most appropriate anticoagulation regimen for this patient? Stop the warfarin, start aspirin and apixaban. Stop the warfarin, start weight-based low molecular weight heparin. Stop the warfarin, start unfractionated heparin at 5,000 units twice a day. Continue INR adjusted warfarin.
Excellent. Wow. Fantastic. That's great.
They did it. So there's like a mess of questions, though.
Okay.
Can I ask you the mess of questions?
Sure.
Okay. So Dr. Connolly kind of put you through the whole thing, but from the practical standpoint, if their dose of warfarin is over 5 and you want to do low molecular weight heparin, what dosages do you give? And I know you said do it adjusted to 10A, but can you tell them practically what you give, how often you get it?
Yeah, again, it depends on the patient's weight. So I'd start with a weight-based dose and then quickly assess whether that's a therapeutic dose for the patient. So I'd do the usual weight-based low molecular weight heparin, administer it twice a day, and then check anti-10A levels within a few days of starting it. And then I would check it once a week afterwards. Same thing with warfarin. I check INRs once a week on pregnant patients who are on warfarin.
And does it change that much?
Generally, it doesn't change much, but there's no guarantee. I wouldn't bet on that.
All right. And then again, how far ahead of time do you, before delivery, do you switch them to unfractionated? Do you hospitalize them? How do you do that from the practical standpoint?
How far before delivery?
Before delivery.
It depends a little bit on, is it a patient this is their first pregnancy or not? In general, around 36 weeks, we would hospitalize the patient. After having stopped warfarin, start intravenous unfractionated heparin as soon as the INR is below therapeutic range, and then proceed with elective delivery.
Okay, and then after delivery, what do you do with the anticoagulation?
Same thing with a surgical procedure. Okay. So start it the same day as the delivery.
Start the warfarin the same day.
Yeah, okay. And then continue aspirin throughout.
Okay, sounds good.
And then don't stop the intravenous unfractionated heparin until the INR is therapeutic.
All right. So last question. 32-year-old woman, 3 weeks postpartum, presents to the ED with chest pain and diaphoresis. No history of CV disease. Blood pressure is 130/80. Heart rate's 90. No murmurs or rubs. Lungs are clear. And here's that ECG. Now, I guess they should get like 100%.
I assume, right?
Okay, exactly. go ask the question here. What's the most likely cause?
Certainly an up-to-date audience has been reading the literature. That's fantastic.
Two claps. Okay, so if you see SCAD in pregnancy, what do you do, though?
Well, we've learned that intervention is not always the best thing. So.
Yeah, so keep those lunatics away from the coronary arteries.
And the mitral valves.
And the mitral valve, and they'll be okay.